Now, I would like to invite Dr. Anju Matthew from Government Medical College, Kottayam, for the case presentation on ischemic heart disease patient posted for TURP. I would like to invite the examiners, Dr. Murli Krishnan, Head of the Department, Government Medical College, Kottayam, and Dr. S. Ponnambala Namashivayam, Head of the Department, Stanley Medical College, Chennai, onto the dais.
You can start presenting the case.
Good afternoon. My topic today to be discussed is ischemic heart disease patient for TURP surgery. This is the case scenario. A 70-year-old male with history of increased frequency and urgency to pass urine for 1 month presented to the hospital with acute urinary retention 1 week back. Past history and treatment. He is a known hypertensive for 6 years on tab losartan 25 mg OD. History of chest pain 4 years back. He was thrombolyzed immediately then with ICU admission for 5 days. Now he is on tab aspirin 75 mg, tab clopidogrel 75 mg OD, tab metoprolol 25 mg, tab atorvastatin 10 mg, and tab sorbitrate. His functional status is 5 to 6 minutes, and he belongs to NYHA class 2. On clinical examination, relevant aspects, his pulse rate is 60 per minute, regular, blood pressure 130 by 70 millimeter mercury, JVP not raised, clinically normal cardiovascular status, no murmurs, no signs of cardiac failure or pulmonary hypertension at present, abdomen is soft, no organomegaly, chest, air entry bilateral equal in all areas, no adventitious sounds, normal ventilation with no motor or sensory deficits, airway, belongs to myelopathy class 2, mouth opening more than 2 fingers, neck movement within normal limit, TM joint more than 1 finger can be insinuated, and spine, no kyphosis, scoliosis, no spine tenderness. Relevant investigations are highlighted here. Hemoglobin 11 gram, total count 7,000, platelet count was 1.5 lakhs, creatinine 1.1, sodium 140, potassium 4.1, prothrombin time 13, INR 1.1, RBS 110. ECG showed left ventricular hypertrophy with Q waves in leads 2, 3, and AVF. Chest X-ray was within normal limit, and the ultrasound showed prostate volume of 60 ml. So this is the summary. The patient is 70-year-old male with lower urinary tract symptoms, diagnosed as having benign prostatic hypertrophy with 60 ml volume, with systemic hypertension 6 years back, ischemic heart disease, with previous MI on treatment for 4 years. He belongs to NYHA class 2. Clinically, patient has normal mentation in sinus rhythm, no signs of cardiac failure or pulmonary hypertension. Airway assessment and spine is within normal limit. Now he is posted for TURP surgery.
So here is an elderly man posted for TURP. It's a known case of hypertension and old case of myocardial infarction. So how are you going to preoperatively assess this patient?
Now I have my anesthetic concerns. First, he is an elderly patient, 70 years. So he has many geriatric related anesthetic implications. Second, my surgery, this patient is having history of ischemic heart disease, so that itself can lead to complications perioperatively and can lead to perioperative MI. Thirdly, the surgery per se, TURP surgery has multiple complications. And fourth, the positioning of the patient, which is in lithotomy position, can further produce compromise for the patient.
One of the major concerns during the preoperative assessment of an ischemic heart disease patient coming for non-cardiac surgery is to risk stratify whether this patient will go in for reinfarction, whether this patient has got a risk of reinfarction. That is what is one of the major concerns during preoperative assessment. In that aspect, how will you assess this patient?
So we have many clinical predictors. First, major, intermediate, and minor. The major predictors are history of acute or recent MI. Acute MI less than 7 days, and recent MI 7 to 30 days. And acute severe angina. Then next is severe decompensated congestive heart failure, history of severe dysrhythmias, significant dysrhythmias, that is Mobitz type 2, AV block, complete heart block, and then other supraventricular tachycardias, atrial fibrillation with uncontrolled ventricular rate, and also severe valvular heart disease.
When you do the preoperative assessment, you approach the case under three bases. One is history, number two, clinical signs, and third, by lab investigations. By the history, how are you going to assess this patient?
This patient, from history, he is having a previous MI, that's his myocardial infarction, probable myocardial infarction occurred 4 years back. So he belongs to
This is not acute myocardial infarction.
Not acute.
This is not a recent myocardial infarction.
No.
This is prior myocardial infarction. So what is the clinical significance? What is the incidence of reinfarction in this patient? It is 4 years old.
Yeah, the incidence of reinfarction is less,
What is the grading of angina in this patient? How do you classify, how do you grade the angina in this patient? New York Heart Association, class 1, 2, 3, 4. You have mentioned it is class
NYHA
2.
class.
What is class 1, what is class 2, 3 and 4?
NYHA class 1 is the patient can do ordinary activity without any fatigue, palpitation or syncope, and he can do all normal physical activity. NYHA class 2, he can do the ordinary activities with symptoms of fatigue, palpitation or syncope. NYHA class 3, he can do when he is doing less than ordinary activity, he will have the symptoms of fatigue, palpitation and syncope, but he is comfortable at rest. But NYHA class 4, his symptoms even at rest.
You said something about METs. What is that, METs?
METs is metabolic equivalence of task. It is the oxygen consumption of a 70 kg 40-year-old male during rest. It is 3.5 ml.
Duke's functional status index. 0 to 4 meds, 5 to 9 meds, and more than 10 meds.
We can classify it as less than 4 meds, 4 to 10 meds, and more than 10 meds. So this patient belongs to, he has meds 5 to 6. That is, he can he is presently doing gardening around his house. In moderate physical activity, he can easily perform.
Depending upon the type of surgery, can you risk stratify this patient?
Yes, again, according to the surgery, we can classify as major, intermediate, and minor. Major surgeries is definitely aortic vascular surgeries, peripheral vascular surgeries, and any major surgeries with massive fluid shifts. Intermediate surgeries, head and neck surgery, carotid endarterectomy, intrathoracic, intraperitoneal, prostatic surgery, and orthopedic surgery. Minor surgeries, endoscopic surgeries, superficial surgeries, breast surgery, cataract surgery. This patient belongs
to which group of?
It's to the intermediate group.
Okay.
Prostate surgery.
Based on the clinical signs, how can you assess this patient preoperatively?
This patient I will accept the complete systemic examination by looking the cardiovascular system. His heart rate is 60 per minute. That is, it's in the target of 50 to 60. He's under beta blocker cover, and the target heart rate is between 50 to 60, and he's having 60 per minute heart rate. Blood pressure, he's hypertensive for 6 years on tab losartan, but he's well controlled, 130 by 70 millimeters of mercury.
Does this patient has any signs of cardiac failure?
No. Signs of cardiac failure, I will look for either right or left ventricular failure. This patient does not have. Right ventricular failure, I look for tender hepatomegaly, raised JVP, pedal edema, and left ventricular failure for S3 gallop, bilateral basal crepitations, and pulsus alternans.
What does this ECG of this patient say?
This patient, the ECG is in sinus rhythm with normal rate of 60 per minute, and it had left ventricular hypertrophy with Q waves in 2-3 leads 2, 3 and
How do
AVF.
you identify left ventricular hypertrophy in ECG?
ECG, left ventricular hypertrophy, we have the Sokolov and Lyon criteria. We can add the S wave in V1 and R wave in V5 or V6. It get more than 35 millimeter or 3.5 micron.
What are the usual changes you expect in the ECG of an ischemic heart disease patient?
In an acute MI, if you are looking, then there will be, if it is ST elevation MI, there will be elevation of the ST segment with tall T waves. If it is non-ST elevation MI, there will be ST depression, and along with that, you have to send for enzymes like troponins to confirm it. And for prior MI, like in my case, we can look for Q waves, which is of delayed onset and usually persist. And you can
ECG in a case of ischemic heart disease. Ischemic heart disease need not be myocardial infarction. What are the presentations of ischemic heart disease? One is myocardial infarction.
It can be stable angina, unstable angina, and myocardial infarction.
So what are all the ECG
coronary
changes
vasospasm,
you may
principal
expect in a patient with ischemic heart disease?
Sir, I didn't hear.
What are the possible ECG changes you can expect in the case of ischemic heart disease?
Yes, possible is ECG changes. First, the rate. That is, there can, if it is a right ventricular coronary artery disease, there will be the right coronary is affected, so the conduction abnormalities will be there, bradycardia will be there, and arrhythmias, bradyarrhythmias will be there, AV block will be seen if it is right ventricular ischemia, along with ST depression or elevation. If it is myocardial ischemia, ST depression in 2-3 AVF, that is in inferior wall, and ST elevation if it is in active myocardial infarction. If it is, and according to the leads I can assess, that is inferior wall MI, I will look for the leads, contiguous leads of 2-3 AVF. Lateral walls, I look 1 AVL, V5, V6. And anteroseptal, I will look for leads, chest leads V1 to V4. And posterior wall, I will look for the reciprocal leads V1, V2. And if I suspect, then I can look for V7 to V9.
ECG might even be normal in a patient with ischemic heart disease.
Yes.
Okay. Right, in this patient, you see deep Q waves in lead 2, 3 and AVF.
Yes.
What coronary artery might have been involved, do you think?
It is the inferior wall.
Okay, what coronary artery might have been involved? Can you tell the anatomy of the coronary vasculature? Normal anatomy.
The right coronary and the left coronary. The right coronary supplies the right atrium, right ventricle, and
SA node, AV node.
SA node, AV node. And
posterior and inferior walls of the left ventricle.
Posterior inferior walls of the left ventricle.
Okay, what are the areas supplied by the left coronary artery?
Left coronary artery, it supplies the mainly the left atrium, left ventricle apex.
What are the branches of the main
it
coronary
has a
artery?
left anterior descending artery, left circumflex artery, diagonal branch.
Diagonal branches are branches of D1, D2, D3. Left anterior descending artery. Okay. What are the branches of the left circumflex artery?
Obtuse marginal.
Yes, OM1, OM2, OM3. What artery supplies the posterior and the inferior wall of the left ventricle? Again. What is dominance?
The right with the coronary which supplies the SA node.
SA node. No. Which artery supplies the
right coronary, left coronary is supplying the
dominant
inferior
artery?
wall.
Right coronary is more dominant
In
usually now.
90% of individuals, right coronary artery is dominant.
Yes.
In 10% of patients, left coronary artery is dominant. So based on the, if suppose this patient has got a right coronary dominance, and which artery is involved in, because this patient has got a deep Q waves in lead 2, 3 and AVF, which is in the inferior wall. Inferior wall is supplied by the posterior descending artery. If the posterior descending artery gets supply from the right coronary artery, that's what happens in 90% of individuals.
Yes.
So this patient might have probably got a right coronary involvement.
Involvements.
Okay.
Yes.
What other investigations you would like to do in this patient?
Investigations, first I will look for the blood investigations, hemoglobin. This patient has 11. I will look for target at least 10. Then total count, this patient was 7,000. I will look for if there was any infection because these patients have recurrent catheterization, and so there is increased chance of infection. Then third is next I look for blood serum electrolytes, serum sodium, serum potassium, which is normal in this patient. Then I look for platelet count.
Any other investigation you would like to assess the cardiac status of the patient?
Yes. Cardiac status.
Apart from ECG.
I will assess, first I have to assess whether further cardiac status is required or not, because all patients need not be sent for cardiac evaluation. So first, if it's an emergency surgery, definitely I'll go ahead with the surgery, not do any further investigations. If it is a surgery which is it is a condition of acute coronary syndrome, decompensated heart failure, severe dysrhythmias, then I will go ahead with cardiac evaluation. If the functional residual
what type of cardiac evaluation you would like to do in those patients?
Yes, those patients I can do exercise stress test, and patients who cannot do exercise I can do for pharmacological stress test, that is with dipyrimidamole stress test and also dobutamine stress echo.
You would like to do coronary angiogram in this patient?
Because
anesthesia for this procedure.
My choice of anesthesia is lumbar subarachnoid block.
What drug you want to use?
I will choose 0.5% heavy bupivacaine.
Any additive you want to use?
I will use fentanyl.
How much?
10 microgram.
Volume?
Total 2.2 ml.
Totally 2.2. Okay. What level of analgesia you would like to have for this surgical procedure?
I should have definitely T10, not above T10 or not below T10.
Why?
T10.
What is that? why you don't want above T10? What is the nerve supply to the prostate and the nerve supply to the bladder?
Nerve supply to the prostate by the inferior hypogastric plexus, sacral S234, and to bladder the sympathetic T11 to T12.
Okay, so you want T10.
T11 to L2.
T11, T12, L1, L2. Okay, why you don't want to have above T10?
Above
Suppose T8, T6.
There are two reasons. One is to assess if whether there is any bladder perforation, or and also if there is capsular sign, which can be only detected if it is below T9. And other is over distended bladder will produce discomfort for the patient if it is above T10.
What irrigating fluid you would like to use intraoperatively in this patient?
What kind? Irrigation fluid. I will prefer a there are many ideal conditions for irrigation fluid. Ideal is fluid should be isotonic, non-toxic, transparent with no electrolytes, easily metabolized.
Why it should be isotonic?
Isotonic because these irrigation fluids, they can be easily entrained into the prostatic sinus, into the circulation, and produce hypoosmolality. So I will want near isosmotic fluid to prevent hypoosmolality.
So what is your choice of irrigating fluid?
My choice will be glycine.
Concentration?
There is 1.2 and 1.5%. 1.2 is
the osmolality of 1.2 and what is the osmolality of 1.5?
1.2 is 175, 1.5 is 220.
What is the normal serum osmolality?
Normal serum osmolality is 280 to 290.
So this is hypoosmolar.
Yes.
Glycine 1.5% is
Hypoosmolar, yes.
Why do you want to use a hypoosmolar solution?
Because our options are less.
You said lot of ideal irrigating fluids are available.
We cannot use normal saline or inhalant because it's electrolyte.
Near isoosmolar.
Near isoosmolar.
Other irrigating fluids.
We can avoid using distilled water, which is high,
if you
zero.
increase the concentration of the glycine, that will obscure the view of the surgeon.
Transparency can be maintained if it is hypoosmolar.
Can you use normal saline or ringer lactate for as irrigating fluids for this?
We can use if it is a bipolar Turp, B-Turp.
What are the other irrigating fluids? Yes, sir, please.
Time.
Okay. So how much of fluid is irrigated? Time is up, or can I?
No,
Time's
you
up.
can, sir. I thought you should ask her what the current guidelines are on ACE inhibitors, and
Okay, sir.
you should ask. I think you were there at race for that Procon.
Okay.
That's fine, sir. You were the
I thought
Procon
I thought
expert on that. I think you should ask her that question.
Yes, please.
Are there any changes in consensus regarding continuation of ACE inhibitors perioperatively?
Yes, actually, if you are giving general, not for this patient, planning for general anesthesia, ACE inhibitors can decrease the stress response to laryngoscopy and hypertension. So that is good. And regarding hypotension, if the patient is well hydrated and not with any other antihypertensive other than ACE inhibitors, you can.
What are the current guidelines now? Is there a difference between the American Heart Association versus European guidelines? Do you know, or you don't?
Yes, American Heart Association says you can. If you
Can what?
give ACE inhibitors
So
on the
they
day of
say that
surgery.
it is okay to continue
Okay to continue on the day of
AC
surgery.
inhibitors throughout surgery, whereas European guidelines say it is all right to continue or it's all right to stop. So there is a change in the opinion that has come, and they say it's not so bad as we once believed.
You said the target heart rate around 50 to 60. So
Yes,
what
sir.
is the present day recommendations of heart rate target on a patient with beta block?
50 to 6.
That may be too low actually. Somewhere
50 to
more,
70?
because that's one reason why beta blockers has become unpopular nowadays. I think there are very few specific indications for using beta blockers.
50
as
to
a product.
70, sir.
Almost 60 to 80. That is
60
what
to 80.
even that's why the present day recommendation.
Yes, sir.
Anju presented well.
Yes, thank you, sir.
You would have asked something in the when he asked about history, the markers of bad, high risk. Number one, you would have asked the self-escalation of the nitro. Most of the patient, they would have prescribed one nitroglycerin while walking, but they escalate it by themselves. They don't give you that history at all.
Okay.
So they start taking more nitroglycerin. That is number one. And number two, patients can have epiphenomenon. It need not be pain all the time. They could have palpitation, they could have sweating, they could have syncopal attacks without pain, especially when they have autonomic neuropathy. So that history is also important so that you can assess the risk based on the history you take. Those are the two comments. And number two, then you said 10 micrograms into the spinal space. Why 10 micrograms? Is it any recommendation there, or you yourself made it?
That's a mistake. I think she was planning to give 20 micrograms.
Okay, because okay. It's very, very difficult to calculate.
What are
10
the
micrograms.
factors that would contribute to the occurrence of the TURP? I think we went more into IHD. What are factors that would contribute to the occurrence of the TURP syndrome?
TURP syndrome is a constellation of central nervous system and cardiovascular system symptoms due to the increased absorption of the irrigating fluid. So the central nervous system manifestations.
I asked what factors contribute to the occurrence of the TURP syndrome.
It is the type of the irrigation fluid, the volume of the irrigation fluid absorbed, the size of the gland, the time of the duration of the surgery, the expertise of the surgeon, and the type of resectoscope used.
Okay. Is it advisable to leave a rim of the capsule?
Yes, sir. Yes, ma'am.
Okay. Right.
They have developed bipolar cautery nowadays,
Yes.
so you can use even normal electrolyte solutions to do irrigation.
How do you manage a TURP syndrome under spinal? And just one more thing. You said this patient was elective, but you also mentioned in the history that he had retention, so I presume he is on a catheter.
Yes, sir.
If the patient has an indwelling catheter, there is a certain emergency in doing the surgery,
Semi-emergency.
maybe a month.
Yes.
It's not elective and can wait. So just tell me how you manage TURP, and that will be the last question. TURP syndrome.
TURP syndrome, I will first, by assessing the mentation, I have diagnosed that there is development of TURP syndrome. So first I will oxygenate the patient, and then I will put invasive monitors like intra-arterial blood pressure and CVP, and I will send blood for serum sodium, ABG, and
I think you should ask the surgeon to stop the
surgeon to
surgery,
stop
isn't
the
it?
surgery,
That
yes,
what you're saying is more like a very slow intensive care management.
yes.
You
First
need to ask the surgeon to stop. Then,
Yes.
then next.
Stop, and then I will oxygenate the patient. Then I
Wouldn't you be supplementing oxygen under a spinal for TUR?
Yes.
So what extra are you going to do?
Then I will restrict the fluids which I give. I will give
Right.
furosemide.
Right, how much?
20 to 40 milligram IV.
Okay.
And then and that is the initial management. Then I'll send for serum sodium,
Okay.
and I will assess
How
the
would
vital
you-
signs,
Okay,
oxygenation.
his BP has now gone up to 150 by
hypertension.
100. His heart rate is 54. He appears to be a little disoriented. You've given 40 milligrams of Lasix. And you have sent your labs. Labs will take some time. If you have facilities for an ABG, you have an ABG that will tell you the sodium. The sodium comes as 118. What will you do?
So my target will be 120 to 125 milliequivalents per liter of sodium. So this is 118. So I'll have to correct it. I will first.
Would you start correcting immediately?
I can, because he's symptomatic, then I have to, because it is less than 120.
So you'll start correcting. You've just given your diuretic. Okay.
Yeah, okay. Wait for the response.
Don't look at me puzzled. This is a situation that you need to handle when you give spinal for TUR.
Because it's less than 120 and he's symptomatic, I will correct.
So how will you correct?
First, I will assess the sodium deficit. That is, my target will be 125. So 125 minus 118.7 milliequivalents is the deficit, and total deficit of the patient I will assess. That is by assessing, that is this patient's male patient, 0.6 into body weight.
That will give you what?
That will give the total sodium deficit.
0.6 into body weight?
Into the body weight into the sodium deficit.
So how much will you give, and what sodium will you, how will you replace sodium?
If it is more than 120, then...
It's not, isn't it?
Yes.
You've got a value.
Yes,
So how much will you give?
So I will give hypertonic saline,
How much?
3%, which is 130 milliequivalent per liter concentration. And for this patient,
How much per liter?
513.
Okay, Ashish is telling me to stop. Okay. Okay, right. So you need to know how much. You usually wait for a brief period after diuretic and see the progress of the patient. If they recover, you don't need to. If they do, you're right. You need to calculate the deficit. The calculation is cumbersome. It goes by that Madias's formula. You can start with about 25 to 30 ml per hour and serially monitor sodium, and you usually stop when you've corrected about 8, maximum of 8 in about this thing, because the symptoms usually resolve with correction of 6 milliequivalents from the deficit. Thank you.
Thank you.
Thank you, Dr. Anuradha. I'm sorry, Dr. Anju Matthew, Dr. Murali Krishnan, and Dr. S. Ponnapala Namashivayam for the case presentation.